Good afternoon, everyone, and good morning to Professor Faisal Han. It's an honor to welcome everyone to today's guest lecture. First, let us express our gratitude to Professor Dr. Randa Yayi Surya Prabandari, MSc, PhD from Department of Health Behavior, Environmental, and Social Medicine. Then Professor Han from School of Medicine, University of Dundee, all the lecturers, and everyone present here today. Our guest lecture today has an important theme, cardiovascular disease and tobacco control, exploring current problems and future direction from public health. And today we have two amazing speakers with us. The first presentation will be delivered by Prof. Faisal Han, then following by the second session presented by Prof. Yai. And after the presentation session, we'll have a discussion session. And to all the participants, you are welcome to submit your question in the chat box at any time. And to start our presentation today, I would like to invite our moderator. Today's session will be moderated by Dr. Bagas Suryo Bintoro, PhD. Dr. Bagas is one of our lecturer in Department of Health, Behavior, Environmental, and Social Medicine. He is also a researcher and director from Center of Health Behavior and Promotion. Dr. Bagas, time is yours.
Thank you, Zilpani. So, good morning for Professor Faisal in the UK, and good afternoon, everyone, distinguished speakers, participants, and colleagues. So, I'm delighted to have the opportunity to be the moderator for today's webinar. Welcome to today's webinar, Cardiovascular Disease.
Recording in progress.
Exploring current problems and future direction for public health. So as we all know, cardiovascular disease or CVD is leading cause of death globally and also including in Indonesia. And their prevalence is rising in global in Indonesia. Also in Indonesia, this trend further worsens by the high smoking rate in the country, with 28% of adults identified as smokers, and shocking 66% of adult males are smokers. The need of effective tobacco control as well as also CVD prevention is urgent, yet the challenges remain significant, including fragmented policies and also inconsistent enforcement. So that's why we will have the discussion today. Today's discussion aims to address the present issue by presenting the latest evidence and exploring opportunities for more effective intervention. We are privileged to have two esteemed speakers with us today. We are fortunate to have Professor Faisal Han from the School of Medicine, University of Dundee, will provide the insight to the impact of CVD. Also, Professor Yayi Suryo Prabandari from Universitas Gadjah Mada who will share the her experience in challenges in tobacco control. So for the participant, I encourage everyone to actively engage during our Q&A session following the presentation of two speakers to make this discussion as enriching and impactful as possible. So without further ado, first let us welcome Professor Faisal Khan from the School of Medicine, University of Dundee. We will show the CV. So please. So Professor Faisal Khan is professor in cardiovascular science, University of Medicine, University of Dundee. You can see that he got the PhD from University of Dundee and also BSc Bachelor of Science with honors from also the same University in Dundee. He has a lot of publication with current one is published in atherosclerosis. It's a very high-end journal for our cardiovascular science, and the others also provide impactful findings for us in the cardiovascular disease prevention. So without further ado, Professor Khan will share the presentation entitled Cardiovascular Disease Risk, Getting to the Heart of the Matter. Professors, you will have 50 minutes for your presentation, and time is yours. Please.
Thank you very much. Can I check everybody can hear me okay?
Yes, clearly.
Lovely, thank you. Dr. Baggers, thank you very much for the introduction, and Prof. Yeh, lovely to see you. Thank you for initiating this opportunity for me to present here. So I'm very, very delighted to meet information with you. So my talk is going to be, I think, quite a broad touch on cardiovascular disease risk. And one of the key things I think I want to convey in this talk are the early mechanistic changes that affect the development and progression of cardiovascular disease, and how these are important for risk stratification, but importantly, what impact these mechanisms have, or how does smoking and e-cigarettes affect these early mechanisms that we can use as markers of determining cardiovascular risk. So I will share my slides with you, and please let me know when you can see this.
Yes,
And if you,
it's
yeah,
yeah, you can see it, but not in a full screen. Now it's full screen and you're ready to go, Professor.
fantastic, lovely. So
Yeah.
getting to the heart of the matter, I've called my talk this because I think the area of mechanism that I'd like you to get the message for is really at the heart of development of cardiovascular disease and progression. So just a little bit of background. I'm here in Dundee in the west coast of Scotland, where the red little dot is. It's a very, very cold morning. I left my house this morning and it was -5 degrees centigrade. Very, very cold, but a beautiful part of Scotland. And approximately we're 13 hours from Indonesia. This is the medical school where we have our teaching, and it's a functioning, very large hospital with 800 beds. Very, very nice, and Prof. Yeh has been there to visit a number of times. So, as we've already heard in the introduction, there's a big burden of cardiovascular disease, and I just want to talk you through how I've structured my talk today. So I'll give you a bit of further information on the burden of cardiovascular disease. And importantly, what I want to convey to you are the limitations that we have for currently assessing for stratification. And these, from a public health perspective, are very important because we rely on risk factors to tell us what interventions and what changes we need to make. And I think there's a great need for novel biomarkers that relate to cardiovascular risk, but which are related to the mechanistic factors that determine how the disease develops and progresses. I'll give you some ideas about some of the lifestyle interventions that we can employ. These have public health implications on a broad scale. And then leading into the main part of the session today is looking at the impact of smoking on cardiovascular risk and e-cigarettes, and some recommendations that might alleviate these harmful risks, not only to the cardiovascular system, but to health in general. So just some background numbers, and again, I'm sure most of you are aware of these, but cardiovascular disease now is the world's #1 killer, affecting nearly 19 million people every year worldwide. And it outstrips all the other major cancers and respiratory diseases that we see. And it's a growing problem. If we look here in the United Kingdom, approximately a quarter of all premature deaths are related to cardiovascular disease. And currently we estimate that in the UK, about 7.5 million people have cardiovascular disease. And the important thing about this number is that these are people who have symptomatic cardiovascular disease. What we don't know are the millions who have subclinical atherosclerosis, but are destined to develop cardiovascular disease. So the actual number and the burden is much greater than that. The biggest component of that, again, as you're if we look at the risk factors here, so this slide shows us the common risk factors for cardiovascular disease is in Indonesia, and the 10-year cardiovascular risk on the very right-hand side of this slide. And it's split up into different colored areas, which relates rurality. So blue is the total areas, red are the urban areas of Indonesia, green are the semi-urban areas, and yellow rural areas. And you can see that hypertension and obesity are the leading risk factors that predispose to cardiovascular disease. And these are most prevalent in the urban areas, which is not surprising. And that reflects as the highest burden of cardiovascular disease risk in urban areas. Interestingly, obesity seems to be the highest, has the highest prevalence in semi-urban areas. But blood pressure is you can see, a major factor here. Looking at the change in cardiovascular disease in Indonesia over 30 years, again, the statistics don't look very good. CVD deaths have almost doubled. And although intervention and drugs are much better, the disability-adjusted life years has not changed over the last 30 years. So we can see with respect to region, Indonesia, again, has the highest burden in South Asia, with about 21% of disability-adjusted life years compared with Malaysia, Philippines, and neighboring Vietnam. Stroke and ischemic heart disease are still biggest causes, and high blood pressure affecting a large number of males and females. Obesity, we've seen, is a major factor, and high body mass index, probably due to the change in lifestyle that not only in Indonesia, but worldwide, taking less exercise, having more mobility with transport in cars, and just activities generally being related to indoor activities. And the main area of interest today's talk is tobacco. Tobacco is still accounting for a significant cardiovascular disease risk, with 13% of males. So to help us understand what cardiovascular risk is, we use biomarkers, and essentially a biomarker is any measurable parameter, biological parameter, that we can use to assess physiological related assessment. So height, weight, blood pressure, heart rate, all of these are biomarkers. And for cardiovascular disease, we have lots of them. We have different types of biomarkers. We have prognostic biomarkers. So someone comes to the hospital with chest pain, you look at their BNP levels, you look at troponin, and if they are high, then they are diagnostic biomarkers to tell you that this person either has heart failure or cardiovascular disease. Then we have prognostic biomarkers, such as for diabetes, glycosylated hemoglobin. That tells you what the long-term risk is. But I think the hardest and one of the most important biomarkers are the screening biomarkers, which have the biggest implications for public health, because these are ones that tell us what's happening on a population basis before the disease is clinically symptomatic. And that's the time when you can make interventions and changes before there are substantial biological, functional, and structural changes within the cardiovascular system. So the concept of risk factors for cardiovascular disease goes back a long way to United States. And I'm sure many of you are familiar with the famous Framingham heart study. Framingham is a small population on the east coast of North America in the United States, has a relatively small population, and it's a population that doesn't tend to move from the area. So for epidemiological studies, it's a perfect population to study. And so in 1948, a group of cardiovascular researchers started to look at the prevalence and changes in cardiovascular risk over time. And so they monitored the population and started to find factors that were related to increased risk of cardiovascular disease. And then they termed the phrase risk factor in 1961, based on the association between factors that we know are relevant for cardiovascular disease, such as high blood pressure. Smoking came up very early as a risk factor. So we now know we have a number of risk factors for cardiovascular disease. Some are modifiable, many in fact are modifiable, and some not so modifiable, which we have no real control over. And so we use these risk factors to estimate what cardiovascular risk is. We also have some now what we would regard as more novel risk factors. Kidney disease, diet, pollution is a major factor which is contributing to poor cardiovascular function. The problem is that when you look at these risk factors, people who are at high risk don't necessarily show signs of these traditional risk factors. And so just as an anecdote, does anybody know who these two characters are? So I'm sure you recognize the middle person, many of you, Winston Churchill. But on the left is a man called Jim Fixx, and he revolutionized the jogging craze in the United States in the 70s. So if we look at our traditional cardiovascular risk factors, we would suspect that Winston Churchill, who's overweight, stressful life, smokes, has the most cardiovascular risk factor. However, look at the age at which these people died. Jim Fixx died from coronary artery disease at the age of 52. Winston Churchill lived till he was 91. This lady, who smoked all her life and has hypertension, is still alive at 100, celebrating her 100th birthday with a cigarette. So what this tells us is that these risk factors, while very good on a population basis, they're not very good on an individual basis. And as medicine moves towards precision medicine, we need to find better ways to identify individual risk. So effectively, this is what we are seeing with our traditional risk factors. We're just seeing the tip of the iceberg. What we are not seeing is what's underneath the water level, which is the biggest burden and people who are destined to develop cardiovascular disease. So we have to question how good our traditional risk factors are. And do we need to look beyond these traditional risk factors? And I think the answer is yes, we do. When we look at people who come to hospital, 50% of them who have had a heart attack, that is their first cardiovascular symptom that they've had. And you hear from the relatives, they've never complained of risk factors, they don't smoke, they have a healthy lifestyle relatively. So something else is going on that we need to investigate. And these biomarkers, as I mentioned, I think are best related to underlying mechanisms that predispose to cardiovascular disease. Excuse me. So in Dundee, we do a lot of work with cardiovascular risk biomarkers, as a lot of the centers around the world do. And we look at the very early changes in cardiovascular risk that cause atherosclerosis and develop all the way through ultimately to heart failure and death. But the key factor that predisposes to all of this, and the initiating factor, is damage to the lining of the blood vessel, the endothelium, and we term that as endothelial damage. So the endothelium used to be considered as a very passive physical barrier to the blood vessel wall, preventing compounds in the blood passing into the blood vessel wall. But we now know from the last 30, 40 years of research that the endothelium is the most important regulator of cardiovascular function. And the understanding of how the endothelium works has really increased our understanding of cardiovascular risk and how precipitating factors will develop and progress cardiovascular disease. And because it's so important, the function of the endothelium is phrased as a barometer of your cardiovascular health. So if the endothelium is healthy, all the factors it's controlling provide a very anti-thrombotic, anti-atherosclerotic phenotype. So it's a balance. When you have no risk factors, your cardiovascular system assumes the phenotype shown on the left of the slide. You're antithrombotic, you're anti-inflammatory, and the blood vessels are in a relative state of dilatation with good perfusion. Contrary, when you have cardiovascular risk factors, when you have smoking, then your phenotype is shifted to the right, where you have a more prothrombotic environment, pro-inflammatory. The vessels start to vasoconstrict, and that will precipitate and promote atherosclerosis. So the importance of this work was really revealed in the late 80s, when it was determined that the most important compound that the endothelium releases is nitric oxide. And nitric oxide has been used in cardiovascular medicine for many years. We use GTN all the time, but its mechanisms were not relatively understood until recently. And these two gentlemen were seminal to finding the importance of nitric oxide. And in 1998, nitric oxide was deemed to be the functions and the discovery, the most important discovery in the history of cardiovascular medicine. And rightly so that year, the key researchers in this area were awarded the Nobel Prize for their work on understanding nitric oxide as a signaling molecule in the cardiovascular system. And so what we now know is that all our traditional and our novel risk factors have their effect on cardiovascular disease risk and atherosclerosis by damaging the endothelium. That's the first sign that damage is beginning to occur. And that's where we want to try and understand how the changes are occurring and when they're changing at that level. So over the years, we've developed lots of ways in which we can test the endothelium and its function using a combination of factors that look at how the blood vessels function, but also by taking blood samples and looking at a lot of biological markers which are related to activities of the endothelium, such as inflammation, such as coagulation, and activation. So we have a whole plethora of biomarkers that we use. So on the y-axis, I just want you to understand that on the y-axis is an indication of endothelial function. There'll be various different units, but essentially, for the purpose of this talk, all of them relate to endothelial function. And you can see that as your number of cardiovascular risk factors increases, your endothelial function progressively declines. Again, on this slide, on the y-axis, forearm blood flow, that's an indication of endothelial function. And on the x-axis, we have increasing doses of a drug that stimulates the endothelium to vasodilate the blood vessels. And if you look at patients who have established type 1 diabetes, you can see that when you infuse the vasodilator drug, patients with diabetes do not have as much capacity to vasodilate their blood vessels, indicating endothelial damage. That's not surprising. But what's more surprising, I guess, is when we looked at young children who have diabetes, children who are 11 to 14 years of age, with no clinical signs of cardiovascular disease, no retinopathy, no microvascular damage. But when we look at their endothelial function, we can see on the left side that compared with healthy controls from their school, the young children with diabetes are already showing early signs of cardiovascular damage and endothelial dysfunction. And importantly, we know that the amount of damage is proportionally related to their glycemic control, indicating that blood sugar level control from a very early stage is paramount to preventing further complications later in life. So if that's people who have disease, what about ostensibly normal, healthy children? Are they free from cardiovascular disease? Sadly, the answer is no, because when we looked at young children, healthy children from populations in Dundee, what we see are factors related to lifestyle, such as obesity, already are impacting their endothelial function. So the more waist circumference, the more adiposity children have, they are showing more signs of endothelial damage. And if this doesn't get addressed from an early stage, these will go on to cause not only functional changes, but structural changes, which will then convert into symptomatic atherosclerotic disease. But other things early in life will affect your endothelial function and then your progression to cardiovascular disease. In this study, we looked at the effects of early breastfeeding versus formula feeding in children. And we monitored their feeding habits in the first 2 years of life. And then we looked at them 14 years later when these children were teenagers and adolescents. And what we saw that was when we corrected for all factors that were relevant, breastfeeding conferred a beneficial effect on endothelial function compared with children who had formula milk fed by their mothers. And we saw that the duration of breastfeeding, again, was weakly but positively associated with endothelial function. So this is really just to show you that very, very early changes in your life will affect your endothelium and prime your blood vessels and your cardiovascular system to develop into symptomatic cardiovascular disease. The importance of endothelial function also is shown that it's a predictor of outcome. So if you have poor endothelial function and you monitor patients for 5-10 years, then the worse your endothelial function translates to poorer cardiovascular outcome, more heart attacks, more stroke, more peripheral arterial disease. So it's a good prognostic marker of future outcome. So if we look at what the actual atherosclerosis timeline looks like, this is what we see. Cardiovascular disease starts from day one of your life. Some will say it starts even earlier, and that your in utero development affects how your blood vessels and your endothelium is primed. And there's the Barker hypothesis, which some of you will be familiar with, that interuterine development affects future diseases, and cardiovascular disease is one of them. So what happens in this slide, as we see very schematically, is that for the first 2 decades of your life, and pretty much up to the age of 40, your cardiovascular disease is silent, but changes are occurring. Damage has occurred to the endothelium. There are upregulation of factors that will promote atherosclerosis, and you start to get plaque formation. But it isn't until you're in your 40s normally that these symptoms become prevalent, and they manifest themselves in the symptoms that we now recognize as cardiovascular disease. But the process has started very, very early on in time. And that's where, again, public health policies, particularly for children, particularly for adults whose lifestyle need modification, need to be amplified and implemented. So you won't be surprised to learn that because the endothelium is so important, that it's a good target for intervention, and changes that can positively affect the endothelium will have a positive outcome. So looking at those diabetic children that we studied, we then implemented a study where we used either intensive insulin therapy with smartphones. We contacted the children every day, checking what their glucose levels were, and made sure that their insulin was matching what their glucose levels were. And then we compared this over a year with children who were on their conventional insulin therapy. And over time, what we saw was that children on intensive insulin therapy were able to significantly improve their endothelial function and cardiovascular disease risk, contrary to the conventional therapy group who showed no change. And this change was also augmented by a 1% decrease in their glycosylated hemoglobin, again, linking that importance of diabetes control with cardiovascular disease risk. Lots of other studies have shown that things like statins, ACE inhibitors will very quickly have a positive effect on cardiovascular disease risk. And we can see here in this slide with statin therapy having effect within 3 days. So statins are amazing drugs. They not only reduce your cholesterol, but they also have pleiotropic anti-inflammatory effects, which are positive for cardiovascular function. But other important lifestyle factors that we can implement, and these again are where public health policies can help, is your diet. So we hear a lot of information about your 5 portions of fruit and veg a day that you should take. And this was a study we carried out in individuals in Scotland who had a very poor diet. They were consuming less than 2 portions of fruit or vegetable a day. And so we randomized in these individuals into 3 groups over a period of 6 weeks. And we had a group who remained on a placebo drink. We gave a manufactured low antioxidant blackcurrant drink to another group. And then there was a very high antioxidant blackcurrant drink that we gave to a third group. And we measured their endothelial function before and after this period of intervention. So what we see here are some very interesting results. First of all, if we look at the vitamin C levels, we can see that they were significantly enhanced in the group that had the high blackcurrant drink, and also augmented, but to a lesser extent, in the low blackcurrant group. And we know vitamin C is a very good antioxidant. As a marker of oxidative stress, we measured F2 isoprostanes, and we can see that the levels of these significantly fell, indicating a drop in oxidative stress. And then the last boxed area is FMD, which is a marker of endothelial function. And we can see that there was a significant improvement within 6 weeks of people who were given a high antioxidant blackcurrant juice drink. So these are ways in which we can introduce dietary factors into improving cardiovascular health. Other ways in which we've seen where you can improve cardiovascular health through diet is, again, we're recommended to consume between 2 to 3 portions of oily fish a week. And in this study, again, we looked at people who had relatively poor diets and randomized them to 8 months of fish oil versus placebo. And similarly to the antioxidant treatment, we saw that individuals on fish oil were able to significantly improve their endothelial function over a period of 8 months. And so these are bits of information we hear all the time from nutritionists of increasing our intake of omega-3 fatty acids. And if you go to health food shops, at least here in the UK, we have aisles and aisles of fish oils and omega-3 supplements. Problem, though, is that a lot of good data now shows that supplementation does not have the beneficial effects that we would like to see, and that enhancement from fish comes from consuming fish itself. So you see areas where they have high consumption of fish, Mediterranean areas, high in fish consumption and fruit and vegetable. They're the ones who tend to have a protective cardiovascular profile. So recent information indicates from Cochrane reviews, from meta-analysis, that supplements do not have a preventative function for primary or secondary control. Again, it's something that we all know, but we don't implement enough in our lifestyle. Lots of very, very good evidence that exercise will significantly improve your endothelial function through a number of ways, which are shown on the right-hand side of this slide, promoting very, very good factors that the endothelium controls. So exercise, continuous exercise on a regular basis is hugely important for primary and secondary prevention. So these are, and I say that in inverted commas, relatively easy, good gain ways in which you can improve your endothelial function without introducing pharmacological therapy. Improve your diet, try and keep your weight down, and recent evidence is now showing that for particular populations, a BMI of 23 is what should be achieved, not 25 for being overweight. Particularly South Asians, there are recommendations that BMIs of 23 and below are what we should be aiming for. So weight loss is a very, very important factor that we have some control over, and exercise. And then, of course, today's big topic is to quit smoking. We know the impact that smoking has. And so for the rest of this talk, I'm going to focus on smoking and what we know about the effects of smoking. Nothing new here for you to see, really. We all know that smoking undeniably has a detrimental effect on the cardiovascular system. And some very, very early studies from the UK and Framingham made a very good link between tobacco smoking and cardiovascular disease. In the UK, we have a big problem as well. At least 15,000 deaths are attributed to smoking each year. Think about it this way. That's the equivalent of 50 planes crashing every year. If we assume that's a very large plane. So can you imagine if the government was told that 50 planes were crashing every year, that planes would still be allowed to fly? No, of course they wouldn't. But yet still governments allow smoking and they haven't banned it. Financially, it's very rewarding. In the United Kingdom, at least, the taxes that the government gets from smoking are phenomenal. So it's a real conundrum why governments have not banned smoking. As we heard in the introduction, Indonesia, unfortunately, has one of the highest smoking rates in the world, 61.4 million out of a large population. You can see what the impact of this is financially. 6 out of 10 households in a survey reported spending money out of their monthly budget on smoking. The effect of this is shown on the right-hand side. Crowding out effect means that then they're not spending as much money on other important products and factors that they need to. So they could be using that more effectively to buy healthier food, to try healthier food. But that limits their ability to spend because they are investing their money in smoking. So the health economic costs, as we would expect, are phenomenal. And in Indonesia, it counts for up to nearly 2.5% of the gross domestic product. Big, big burden. E-cigarettes are beginning to become a big problem, and we are seeing a decline in the number of young people smoking tobacco. However, the number of children and young people vaping is going up in a striking manner. And it's being promoted by lots of, if we call them, well, they're called influencers, famous people who are seen smoking or promoting the use of e-cigarettes. And there's still a very big misconception that e-cigarettes, electronic cigarettes, are less harmful and they're good alternatives to smoking. And we really need to change that dialogue because there's very good evidence that definitely isn't the case. So e-cigarette use in Indonesia also has skyrocketed from 0.3% of the population to 3% in recent data from the World Health Organization. So it's a problem that is growing worldwide and in Indonesia. With regard to the effects of tobacco on endothelial function, we see some evidence here, again, on the left-hand side. The clear dots are smokers, and we can see that compared with non-smokers, they have much poorer endothelial function. You can improve it with vitamin C. Again, remember the vitamin C provides your antioxidant capacity. So by improving your antioxidant capacity, you can change some of the detrimental effects. We wouldn't recommend that it's something you can do if you're smoking, but we don't recommend that's a way to go forward. Ideally, you want to quit smoking. And we can see on the right-hand side slide as well that the immediate effects of one cigarette or one e-cigarette on endothelial function, showing a decline within very, very short time before and after smoking either an e-cigarette or taking water vaping with hookah smoking. So the effects of cigarette smoking are immediate and long-term with regards to endothelial function. We carried out the study not too long ago, trying to see if we could get people to switch from traditional tobacco smoking to e-cigarettes and what impact that would have on endothelial function. And within a short time, so we had 3 groups. One group maintained their tobacco smoking. One group, we replaced their tobacco smoking with e-cigarettes that had nicotine in them. And then the third group had e-cigarettes, but without nicotine. And over a relatively short period of 4 weeks, the groups that changed from tobacco smoking to e-cigarettes were able to show a short, acute improvement in endothelial function. So while that's some positive news, it's a less harmful way. The message still should be not to smoke at all. But at least it shows you that trying to shift away from tobacco smoking, if that's a pathway to stop smoking, can be beneficial. So whether you smoke traditional cigarettes, whether you vape, or whether you use hookah, this slide here shows that the odds ratio and the evidence for cardiovascular disease are, I think, quite striking and very, very clear. Very, very strong effects on stroke, very, very strong effects on myocardial infarction, coronary artery disease, and other health risks as well, COPD, lung cancer, and also indicators of endothelial dysfunction and arterial stiffness. So very, very good, strong evidence that the effects that all 3 of these formats of smoking, the effect they have on the cardiovascular system. So this slide just shows you why, some of the reasons why these factors are so harmful. If you have a look at the main toxicants, they are substantial in tobacco, in hookah smoking, and in e-cigarettes. They have lots of very, very harmful chemicals. And you can see the damage that these chemicals do to oxidative stress, to inflammation, to thrombosis, and importantly, to DNA damage. So there are lots of cellular changes that these products are having. And the slide at the bottom just shows you the more schematic changes that occur in the endothelium that then predispose to the later changes that we've talked about. So what are we doing to try and curb these effects? Well, thankfully, many countries are making recommendations and updates as evidence emerges. And I guess one of the reasons why I wanted to introduce this endothelium concept to you is because this is what provides us with evidence that these changes have beneficial effects. And then that evidence can be used on a public health basis to roll out important messages to the countries. So, for example, in the United States, they have tried to regulate, the FDA has regulated sales of tobacco quite stringently. And in 2016, the FDA has included water pipe and e-cigarettes in the same way so that they are regulated. The American Heart Association has started a campaign to ban all e-cigarette sales. And in France and in UK, we are also looking at completely banning disposable e-cigarettes. And there is also the worrying statistic and claim that teenagers are being addicted to e-cigarettes, which then is converting them into going on to using tobacco smoke because they get addicted to the nicotine in e-cigarettes, and they are now converting to tobacco smoking because they're wanting that greater effect of the nicotine. So most of the countries have agreed to recommended guidelines on protection of public health policies on how to regulate sales and control of tobacco. And e-cigarettes. And so other ways in which public health policies can try and help is to ban smoking in workplaces and in closed places. So here in the UK, smoking indoors is completely banned. It's banned in restaurants, in shops, in shopping areas. And some countries even have a complete ban in all indoor areas. So looking worldwide, we can see where around the world sales are banned of e-cigarettes and where the sales are regulated and not regulated. And the good news, at least, is that Indonesia is one of the places where sales of e-cigarettes are regulated. And that's a very, very important factor that needs to be maintained. So some of the other things that Indonesia has introduced, it has prohibited smoking in areas such as health facilities. It's requiring also local districts to create smoke-free areas where no smoking is permitted. Raising the smoking age limit is always very, very good. And importantly, curbing cigarette smoking. Very, very difficult to do, especially when access to internet and popular media is very hard to control. And these influences can be very, very profound, particularly on young people. Whereas again, as we heard at the start, there are challenges in implementing these policies, converting governments to translate these into national and local law can be problematic, and it's a factor that we see in our country as well. So just to bring this talk to a conclusion, I think hopefully I've convinced you of some of the biological evidence that smoking and e-cigarettes have a profound effect on cardiovascular disease risk. And these risks will occur very, very early on, from as soon as you start smoking. We've seen the effects of one acute cigarette smoking on endothelial function. And we've also seen that although the e-cigarette vapor is less toxic, e-cigarettes and water vapor smoking equally has detrimental effects on endothelial function, largely being promoted through an increase in inflammation and oxidative stress. And important to emphasize that water pipe smoking is not less harmful than smoking. I think the British Heart Foundation recently calculated that one session of shisha smoking, so you see in places, particularly in the Middle East, people smoking shisha for the whole evening. And they equate that one session to 100 cigarettes, tobacco smoking cigarettes, the effects that session has. So again, important to remember that these are very, very profound effects. Sorry, the slides are progressing in the wrong direction. So the use of e-cigarettes and water pipe smoking is concerning. It seems to be popular amongst young people, but the health impact of it is very significant and severe. We need recommendations on how these products are regulated and how they are made available to young people. And I think we still need future research to look at what the long-term effect of these e-cigarettes are, not only on the cardiovascular system, but particularly on the respiratory system, when we know now that microparticles inhaled into the lung have significant impacts. However, regardless of all of these, the most powerful message that we can try and promote is to stop smoking and to try and implement that in a way that stops any effects of inhalation of smoke or particles into your body and into your cardiovascular system. So that's my very last slide. Thank you very much for listening, and I'll be happy to take questions in the discussion part of this after we've heard from Prof. Yeh. So thank you very much. I will stop sharing my screen just now.
Okay,
Thank you, Professor Faisal, such a wonderful and enlightening talk. Uh, your insight on the role of biomarkers in cardiovascular disease prevention really align with my previous research. So it's also aligned, give us understanding the role of biomarkers in the cardiovascular disease prevention, and especially to understand their primary role in the prevention and screening, of course. And ladies and gentlemen, to delve deeper on the tobacco policies that also has been mentioned by Professor Faisal Khan as a critical preventive measures for Indonesia, recommendation for reducing the cardiovascular disease in Indonesia. Then let us now turn to Professor Yayi Prabandari. Professor Yayi is a professor in Faculty of Medicine, Public Health and Nursing, UGM. Let's us see the CV, please. So, Professor Yayi Surya Prabandari is a professor in and also the head of Department of Health, Behavior, Environment, and Social Medicine, Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada. She had his PhD from Newcastle, University of Newcastle, Australia, in community medicine, master degree and bachelor degree from Universitas Gadjah Mada. Professor Yayi is, figure in the tobacco control in Indonesia. Her latest research including working with the UK, also University of Glasgow, for feasibility of a peer-led school-based adolescent smoking prevention intervention assist in culturally different middle-income countries. He also has recently finished her pilot project on communities facilitating increasing smoke-free home, COFRES, from 2022, and she is now waiting for the scale-up grant for the same intervention, COFRES, with University of Stirling. Her publication includes also a comprehensive tobacco policy program in the mining industry, in frontiers of public health, and also a lot of more publication in tobacco control and also public health promotion. So Professor Yayi today will have the discussion on the challenges and the opportunities for tobacco control, with a focus on policy and intervention direction in Indonesia as one of the low and middle income countries. So Professor Yayi, you will have 40 minutes for your talks, and time is yours. Please, let's welcome Professor Yayi.
Okay, thank you very much, Dr. Bagas. Could you hear my voice?
Your voice is audible clearly.
Okay, so hello, Prof. Khan. How are you? Yeah, and I just met Prof. Kandes and she send regards to you. Yeah, so is it already come up?
Yes,
The tobacco
it's now in
control.
full screen, Prof.
Okay,
Yayi.
yeah, it's already full screen, yeah. Okay, so tobacco control challenge and direction for future policies and intervention. And then I will talk about the tobacco smoking in Indonesia, the fact and the pattern, and then tobacco control essential prevention measures, and then tobacco controls in low middle income countries, challenge and opportunity, and then also potential direction for policies and intervention in low middle income countries in Indonesia. So first, here's is the pattern, yeah, of the tobacco and e-cigarette use, that 10 years progress, while the e-cigarette use is, I think, is triple, yeah, from the 0.3 to 3%, even though still, yeah, this is combined, female and male. So that's why 36, because if we talking about the man is more than 60%. So there is a dramatic increase in electronic cigarette that observed from 2011 to 2021. But tobacco use and smoking is light, yeah, And then in the past 10 years, is also a rising demand on smoking cessation among tobacco smokers. Although the change, the number is not really decrease. Yeah, so the second figure that show that I think the people that attempt to quit is increased for the last 10 years. And then as well as the smoker that already advised by the healthcare provider. So that's the good things, even though the smoking prevalence is still lightly only decreased a little bit, but yeah, we saw that the attempt to quit and then the advice has increased. And then this is the smoking daily and electronic cigarette use that also the last 10 years from the National Health Survey. This is we have the, I think every 3 years, yeah, the 2013 and then 2018 and then 2023. There is a slightly decreasing, yeah. Indoor smoking expect also a little bit high, yeah, 80%. And in 2023 is still, yeah, it's just almost the same. There is an increasing, but the increasing is zero, I think 0.9. Yeah, this about the smoker age 10 to 11, 10 to 18 years old. Yeah. So this is I think it's still alarming because we still have like 2013 to 2023 a little bit increase, even though the 2023 compared to the 2018 is a little bit decrease. So the result from the National Health Survey showed that smoking in young people had declined substantially from 2018 to 2023. While the this is the proportion is already lower than the plan RPJMN target is the plan of the Ministry of Health. And then when we talk about the nicotine, the advertising, and then the young people that already notice advertising, promotion, and sponsorship. So any advertising or promotion, there's most because we still not banning. There are a few of cities that already have regulation for banning outdoor cigarette advertisement, but still very limited in Indonesia. Yeah, a certain cities, but we still have the advertisement in most countries in Indonesia. So that's why more than 80% our young people, they notice any advertising promotion or sponsorship. Even in the store and then on TV, yeah, even though now is mainstreaming TV is not really television, and then in the billboard, yeah, and then the people that exposed to the secondhand smoke is also still more than 80%. This is in restaurant, inside the house is more than 70. And then in public transportation is a little bit decreased because nowadays, I think most of the transportation, they ban the smoking inside of the, not only in the flight, but also the train and then the bus. Yeah, even not all, but it's already. And then in government building, and then also in workplace and healthcare facilities. So the number is already decline. Yeah, because of smoke-free area that now is already implemented in several of the settings, including the working settings, healthcare settings, and then also as well as the education setting. This is the smoking prevalence by province in 2023. So the higher prevalence of daily smoking was observed in provinces in Java as well as in Sumatra. Yeah, when we talk about the east side of Indonesia, so a little bit lower than in the west side. Yeah, the impact of smoking in Indonesia, I think we have higher likelihood of outpatient and inpatient visit, and as well as the morbidities such as diabetic, hypertension, tuberculosis, and then there is also a study that higher risk of mortality, decline the quality of life. When we talk about economy side, there is an increase of healthcare costs that attributable to smoking, and then the GDP loss, as well as the productivity loss is almost 183.7 billion among the working age population follow up until their retirement, and increased poverty rates and gaps, particularly in rural area. Then also we found that tax loss due to the illicit consumption. So smoking has been associated with a number of health economic impact in Indonesia, from the micro level impact till the large scale ones. So what have we done? Yeah. Actually, from the international level, there is a framework convention on tobacco control that unfortunately Indonesia has not yet ratified. That within the framework convention, we have to reduce the demand by the price and tax measures, regulation on tobacco content, labeling of tobacco product, tobacco advertisement, protection from exposure, and then also reduction of supply, including illicit trade, sales to and by minors, and viable alternative activities. Even though we haven't ratified this framework convention on tobacco control, we already implement a few of this. For example, we already increasing the tax. We already have the pictorial health warning. And then I already mentioned that in few of cities, they already ban the outdoor advertisement. And then the protection from exposure, we implement the smoke-free area. And then yeah, I will show the regulation that related to this one. So recently, there is a government regulation number 28 in the 2024 that coming from the Ministry of Health. This is coming from the government of Indonesia, but related to the health. Yeah. So the government regulation related to the health that is, I think, is improving from the regulation in 2012. So now we already stated that electronic cigarette, yeah. So because we have many forms of tobacco, for example, rokok, cigarette, and then cigars, and then leaf cigarettes, and then sliced tobacco, and then liquid tobacco, and then e-cigarette are tobacco product that is already in this regulation. That's also include the cigarette that contain nicotine or other materials. Yeah. So electronic cigarette have been accommodated in the regulation, the new regulation, but not yet in the 2012. And the government regulation also already trying to include the prohibition of tobacco product, including e-cigarettes, in the production, selling, advertising, indoors and outdoor settings. And then, however, the ban of sale tobacco products and e-cigarette does not apply to a location utilized for selling activities. And then the production of banned tobacco products does not apply location utilized for manufacture operation. So smoke-free area, according to the government regulation 28 2024, is include the prohibition of cigarette, electronic cigarette, in addition to tobacco product. This is also additional clauses related to indoor and outdoor restriction. So there is already additional compared to the government regulation in 2012. So because of a lot of movement coming from the bottom up. I mean that from the municipality, from the district, that we already implement the smoke-free area is most in Indonesia. So 82 point, I think is closely to 82.5, yeah. District in Indonesia already have the smoke-free area regulation. And then 63 district and cities have local regulation, peraturan daerah. And then half of the provinces Indonesia already have regional head regulation, peraturan kepala daerah. So this is in the province level, and then in the district level, we have more than 60. So when we see the red one is still we found in the east and in Kalimantan and also in Sumatra. In Java, I think mostly they already have it. Yeah. So the red one is that the district or provinces that haven't had the smoke-free area regulation, while in the green one, they already have the local regulation and the uh, regulation health warning. We already add the white of the. I hope that my voice is still there. Yeah. 40% because they state that the Wi-Fi is not really good. 40% to 50%, the regulation, the new regulation, and then start with the word warning using yellow letters. And then image must be printed in color. This is state here. Yeah, so in the new regulation that requires the inclusion of image and text of health warning on e-cigarette packaging too. So not only the cigarette, but also e-cigarette and a larger size. However, this regulation does not include a clause of writing information on nicotine or tar content in the packaging. So it still need to be revised or improved. And then on the labels of tobacco product and electronic cigarette, that must be included the statement of contain nicotine and then a sentence prohibiting selling to person we adding, because before we are more than 18 years old or 18 years old and above. Now the new regulation is 21 years old of age as well as the pregnant woman. So, and then the mandatory include no safe limits and contain more than 7,000 chemical and more than 83 cancer causing substance for tobacco product. So we already add the age for purchasing cigarettes. So from 18 years old and above to 21 age and above. And then in the new regulation, we also already including the e-cigarette for the misleading promotional description. For example, ultralight and then mild. Yeah. But there is an exception that tobacco product that have obtained the brand certificate for tobacco product carried by passenger new crew members of transportation border crosses. This, yeah, we still need to be concerned. Yeah. So, and then for the technical guidance for the smoke-free area, prohibition of sale tobacco products and electronic cigarettes by self-service machine and then retail sales. So we already banned the stick cigarette and then placement of product area around the entrance and exit that heavily travel areas, and as well as there is a regulation on sales within 200 meters radius of educational unit, especially the schools and children playground. And then this also regulate the use of commercial website or electronic application and social media services, except for the age verification. So in the bottom, that the sales ban in the regulation cover electronic and then age limit and then prohibition of retail sales and at certain location. So for the marketing, in the new regulation, this also already banned for the advertising tobacco product and e-cigarette in the digital based social media. But advertising is permitted on commercial website or electronic application, point of sale, outdoor media, television, radio, and print of media. So still there. Each medium has own detailed advertising requirement, but requirement include for
Prof. Yai, we lost your voice, I guess.
exit, and then to use the machine and screening restriction from 10 o'clock. Yeah. Now
It's
you
back again.
still hear me?
No, it's clear.
No. So I use Tetrick because the Wi-Fi of the hotel is not good. Sorry for that. So maybe I will not use my camera, yeah?
So now your screen sharing is off,
okay.
and it's now
It's
sharing.
okay, yeah.
Number 4, fiscal
Yeah.
policy.
Yeah, okay.
Okay. Sure.
So this is the movement or the change of the fiscal policy from the 1932 till 2020s. Yeah. Well, for example, the beginning of the tax system is already in the past, and then after 2000, there is a tax increase, and then also annual increases become more common for cigarette, and then roadmap, as well as annual excise tax increase, and trying to simplify the taxation continue by Ministry of Finance. Yeah, and then beside of those things of the regulation, we also have national campaign. Tobacco campaign is run by the government from the Ministry of Health, national and subnational, in the provincial levels, in the district level, as well as local and international non-government entities such as the Indonesian Public Health Association, World Health Organization, as well as in the higher degree. For example, Universitas Gadjah Mada also trying to campaign about the tobacco related diseases, and then we also implement smoke-free campus. And we in the umbrella of the healthy university, we already also including the smoke-free area campus. So the Ministry of Health also released the guideline for the World Tobacco Day, including activities like here. And then this is recommended campaign is also media, and then social media, webinar, workshop, and then etc. So what are the challenge and opportunities? Indonesia, it's very hard for controlling the tobacco, because the tobacco has already arrived in Indonesia, I think, in while we are still in the war, 1820s, and then this brought by the colonial, and then it spread up easily when one company already built in Central Java in 1820, then become more than 1,000 cigarette industry in 2000, because this industry is like, give a lot of benefit. This is the challenge. So that's why Indonesia and other low middle income countries spoiled by tobacco industry from the money that they give to the government as a tax, media, and then sometimes they also pay the political parties. They still give sponsorship, and then facilities. And then, evidence the impact of tobacco cigarette smoking on health economies has not yet campaigned, even though we already campaign, but maybe we still a little bit less than the tobacco advertisement. So industry marketing should do evidence to against scientific evidence. They also have marketing image with the as the cigarette is they claim as a Indonesian heritage, especially in the kretek, because kretek using cloth. Cloth is really original from Indonesia, but not the tobacco. And then this is they use many kind of marketing But we trying to have the smoking cessation approach in Indonesia that started in the 2020. So we have 2021 technical guidance by the Ministry of Health. So we already have quit line, phone and social media, and then the Ministry of Health already trained some district, the health professional to give counseling, yeah, in the primary healthcare, and as well as a few of district hospital. So there are some issues in the current smoking cessation approach. Yeah. So in 2022, there already 134 district and municipalities already provide smoking cessation service or usaha berhenti merokok. And then this is behind the target of 175. Yeah. So still below. But even though there is already a service, but the utilization is still low, and then still need to be integrated into the other health program. And yeah, we also lack of evidence of supporting the effectiveness of this service. So when we try to benchmark, yeah, in Malaysia, for example, yeah, they have already a smoking cessation service introduced in 2016 by the government. And then the service is professional advice from the health worker. And then they also use drug. And then they also have mobile quit support. Yeah. And yeah, this is the user can access various support. This is in Malaysia. It's still low income, but they already have a system mechanism for smoking cessation. Well, for health workers, they also support, yeah, providing clear advice, and then they have like the algorithm, yeah, that they involving the providers, health provider, including medical, dental, pharmacists, and nurses. Even they have referral system, yeah, to the specialized services. In Thailand is also advanced in health promotion, yeah, as well as in smoking. In 2010, Thailand has launched the free and comprehensive smoking cessation service program under the Smart Quit Clinic program that led or held by the multidisciplinary team to be accessed by the citizen of Thailand. And they involving many health professionals, including physician, nurses, nursing assistant, pharmacists, dentists, public health officer, psychologists, as well as practitioners in traditional Thai medicine. And they also have the logarithm for the service. So there are some key lessons from the smoking cessation approach in other countries. So they integrate with other public health program and using the multidisciplinary approach and incorporate cultural sensitive approach. Even they including in the insurance, we haven't yet. Yeah, so the National Insurance of Indonesia not pay for the smoking cessation, even though the quit line is free. Yeah. Pharmacotherapy provision, they give it in Indonesia, not yet. And then intervention for specific population. And then the provision also outreach to community schools and workplaces that we have to follow. Yeah. So the potential direction for policies and intervention in low middle income countries in Indonesia. So I trying to use the multi-level of health promotion that we have the target for individual, for example, for the information, education, and communication. So healthy without tobacco that can be spread, yeah, all over all settings. And the organization, for example, schools, and then working place, they can have policies, yeah. For example, like I already mentioned, in Gajah Mada University, we already implement smoke-free campus. And in the community, there are in Yogyakarta, actually, they already have it, the movement of smoke-free home village that can be spread all over Indonesia. And then we still have to maybe revise again the regulation, even though the regulation of 2024 has already improved from the regulation from the 2012. So this is the multi level of health promotion actually is following the socio-ecological model. While beside the interpersonal, we also have the institutional factor, community, as well as public policy. And this is I got from a few of systematic review that the tobacco measures that effective, including behavioral intervention, but this is a little bit individual with and win stage-based recruitment strategies for smoker. And then group counseling is also found a little bit effective. And then implementation of quit smoking assistance in many settings. This also found that effective. And the individual counseling should plus the nicotine replacement therapy and pharmacotherapy, such as in Thailand, in Malaysia. Yeah. Professional training is also show effective for the reducing the smoker, and then still continue campaign through the short message media, including real-time video. But don't forget about the policy instrument, for example, prohibition of advertising, cigarette sponsorship in any activities involving teenage, and also healthy lifestyle program. Increase the tax, because we already increased the tax, but not yet as our expected. So it should be increased 60%, but now it's still 40 or 30%. And then makes cigarette become expensive. In Indonesia, cigarette is still very cheap compared to other countries, and only one pack can be purchased, no single cigarette. This is already in the regulation, new regulation 2024, but we have to observe and then following and then monitoring, because I haven't seen some places still apply that you can have the stick and then only can sold to those age 21 years old. That is also be monitored and in certain place, and the smoke-free should be expanded, and the image of effect of smoking should be enlarged. We already enlarged from 40% to 50%, but maybe we can follow up like Thailand. They become the 80%, or Brazil is 100%. Yeah. So this is the measure for reducing smoker that based on several references: individual counseling, health professional health services, and then group counseling, as well as implementation call center beside the policy instrument. And if we trying to learn from Australia, Australia also have the multi-level of the activities to reduce the smoker. They have intensive intervention running by the specialist clinic, and the psychologists and then the psychiatrists that already have trained in the smoking cessation. But the GPs and allied health, like nurses, they also receive training of brief intervention, and they also give the pharmacotherapies. Meanwhile, they also have campaign that allowed in media, and as well as legislation. They have the tax, and is of course the price of cigarette is higher in Australia compared to Indonesia. Yeah, one pack, if I'm not mistaken, is already $15, means 150 thousand rupiah. Yeah, so it is I think more than 300 or 100%, not 100%. Yeah, I think 500% higher than in Indonesia. And the ban is already in many settings, as well as we only can purchase the cigarette only in certain place and only have one pack. And then health warning is everywhere. There is no cigarette advertisement outdoor in Australia that I found when I was studying there. So there is no cigarette advertisement on TV. There is no cigarette advertisement outdoor. Yeah, so the recommendation for further development of one of tobacco control, for example, smoking cessation, that because I already cited some evidence. So provide clear mechanism for referral system services, including the types of health workers, and as well as incorporate pharmacological measures and integrating the smoking cessation service, including quitline with primary and referral healthcare services. that particularly with regard to the launch, because we just launched the integration of the primary healthcare, and also provide clear mechanism for the community, school, and workplace, like in another country. For example, in Malaysia, revisit the possibility of extending the financing mechanism in the insurance, because we haven't yet have the mechanism from the national insurance, and then ensure the integration service utilization and monitoring data from the facility level to district, provincial, and national level. And based on, this is my last slide, based on the review on systematic review, I found that Hoffman and Tan review 612 systematic review and 59 review covering 1,150 studies. These reviews show that the results show that smoke-free area is the intervention that most supported by the government. Like in Indonesia, we already more than 80 district and municipality, even though in the level of province is more than 50. And then the tax increases consistently reduce the number of smoker. And the cigarette pack intervention and anti-tobacco campaigns in the mass media also reduce smoking, especially when followed by the broader intervention such as the policy instrument. And then financial intervention for smoking cessation is also effective for target smoking in reducing smoking cessation product. So that's my presentation. Thank you very much, and return back to the moderator.
Thank you, Prof. Yayi, for your wonderful presentation. So now as we already have two speakers, Professor Faisal and also Professor Yayi, we invite our speakers to have the discussion. We have a discussion from the chat room, but before we go to the chat room, I would like also to invite if anyone want to open their mic to have the discussion in person. I mean, if you want to talk. No? So yeah, then we can go to the chat room. We have Mafira Lalisirani for about the NRT. So it's for Prof. Faisal. Do you have any insight about NRT for smoking cessation? And is there any experience on having NRT in Dundee or in the UK? Here, because here in Indonesia, we just approved the NRT, one of the chewing gum. If we might, it's only the chewing gum. We don't have the lozenge or the patch. Then she would like also to ask Prof. Yayi about the regulation in restricting cigarette purchase to individual age 21 and above. Maybe it's will be a challenge, because not all the cigarette sellers, like in kiosks, verify the age. So if you have any comment on this, and maybe it will be also wonderful to have Professor Faisal to learn about what is the implementation of cigarette buying or legal age there in the UK, because then in Indonesia we still see children before 18 buying the cigarette. So maybe time is for Professor Faisal.
Thank you, and thank you very much for that question. In Dundee, we haven't done any other studies except for the ones with e-cigarettes, with trying to replace nicotine. So one of the slides had a diagram and a graph showing e-cigarettes without nicotine, which also showed a beneficial effect. But we haven't looked at patches. I think we did try to explore this, but part of the problem is that trying to get adherence to patches was very difficult, and people were very quickly switching back to cigarette smoking. I think socially there's a perception that having that something in your hand to smoke is a preferable way to try and reduce the nicotine through the e-cigarette rather than with a patch, which doesn't seem to give you the same effect. So I think there's a combination of reasons why the patch, we haven't been successful to get people to adhere in the way that we can then study that formally. Broader, to be honest, I'm not sure what the UK evidence is for patch replacement with regards to evidence on cardiovascular risk reduction. I haven't kept up to speed with what that information shows in the literature. Although I think the use of patches has hugely declined in the UK since e-cigarettes have become available. And part of that largely is because the perception still is there that this is an okay way to reduce smoking, or it's an effective way and a lot less harmful. But as we've discussed, clearly that's not the case. So I think in answer, if people would adhere, although I don't have the evidence, if people would adhere to nicotine replacement therapy, then yes, endothelial function would improve. And that one slide on the right-hand slide, the one I showed you, certainly showed that switching from tobacco smoking to e-cigarettes without nicotine over a 4-week period improved endothelial function by 1%. And in real terms, what that equates to, a 1% improvement in that biomarker equates to a 13% reduction in CVD risk over 5 years. So if you are to maintain that 1% improvement in your blood vessel function, then your 5-year risk is reduced by 13%.
Yeah, thank you, Professor Faisal. So do you want to then go for the experience of age verification, or we should go to Prof. Yai first for the age verification comment?
We can pass to Prof. Yai for that one.
Okay, so Prof. Yai, Mahvira Laili Sirani has the question of the age verification. So what do you think about the age verification, as you recommend also to increase the age to 21, like other countries? So do you see any challenges, and is there any best practice for the age verification?
Yeah, in Australia, when you purchase cigarette and your face is not seems as adult, I mean that, yeah, Asian people usually, the Australian is difficult to predict, yeah, the age though. So you can ask the identification. For example, the personal identification KTP, ya, the kartu pengenal, kartu penduduk, ya, or if outside from the country, so passport. But yes, it is very challenging because in Indonesia, rules is rules, regulation is regulation. For example, smoke-free area, this need to be monitored, and there should be a monitoring team, like in Yogyakarta. We have monitoring team that monitor in some places, for example, public places, for monitoring the smoke-free area. I think for the selling of tobacco product that more than 21 years old, for the requirement for purchasing, it should be also be a monitor from the government. And in other country that I know, in Australia, the seller will be fined too if they sell for the underage. So they usually ask the identification. If they're not sure, this is already in Australia at that time is 18 years old, yeah. So, but I have friend that already in graduate program, but maybe because this is Asian people, they cannot predict. Yeah, he was asked by the seller, where is your identification? Yeah, he was, I think, 28, if I'm not mistaken. But yeah, because the face is baby face, so they will ask. But if they sure already that you are already mature, so they will not ask. So I think this also can be applied in Indonesia. And then yeah, the fine for the sellers on the shops that sell the cigarette should be fined too, not only the person who purchased the cigarette. So, but as in the smoke-free area, that should be a team, yeah, from the local government to monitor the implementation of this regulation. But because in Indonesia, if there is no team, I think like using helmet, wearing helmet is need to be monitored for a certain years. Even until now, there's some motorcycle riders still breaking the law. They don't wear helmet. So in Indonesia, regulation is challenging. But I think like in Yogyakarta, because we have now smoke-free area in Yogyakarta is already, I think compared to, for example, other places, it's already implement. Even though in some public places still need to be monitored, but some places is already okay. So this, Mas Pakas.
Thank you,
If
Prof. Yai. Yeah, Professor Faisal.
Yeah, just to add, and I think the age restriction in UK is 18. I think the big difficulty, though, is what penalty will government impose on people who smoke under the age? And we have the same issue with alcohol purchase and alcohol consumption. So there are fines which the vendors are responsible for. They have to check the ID, but it's still very easy to get purchase or get hold of cigarettes. And I think the policy of monitoring the use of it, not only the sale of it, is what's hugely important, and how that is done and what the government does in the way of penalizing individuals who are in possession of cigarette smoking below the age is something that's going to be very difficult to police and to implement. If the charges are significant and severe, then I guess that will be a deterrent. But how that will be imposed, I think, is going to be difficult. So I agree with Prof. Yai, the monitoring of it. I mean, for example, in our hospital, we have lots of clear signs that outside the direct hospital, smoking is prohibited. There are announcements made, yet you walk outside the hospital and you'll see 10, 15 people smoking. Because nobody does anything, or there's no implication for those, people will continue to smoke. And I think unless you introduce some stricter penalties, then bringing that age restriction into tight control is going to be hard.
Thank you, Professor Faisal. So I think we don't have any other question, but I would like to ask for my personal question for Professor Faisal. So we know that the biomarker has remarkable predictive power, but then is there any biomarker that can be a nationwide screening, or what is the recommendation of using the biomarker to implement in the LMIC in Indonesia? It's for the implementation side, and also from the financial side. Any comment, Professor?
Very good question, and one that we get asked a lot. So I think the balance that we need to try and achieve, and we haven't had that yet, is something that is affordable but easy to implement and easy to do in a quick way. So the reason we have the current biomarkers is because, and we rely on those, is because they're relatively easy. We can take a blood sample, we can measure person's height, we can measure their blood pressure. I think the ultimate goal would be to have a panel of biomarkers. So if we think about endothelial function, the slide I showed you about all the things the endothelium is doing, we want to capture as much of that information in a biomarker, which we don't have at the moment. At the moment, biomarkers for endothelial function are complex. They require, so in my laboratory, we have sophisticated pieces of equipment which are expensive, which are time consuming. They give us fantastic results, but we couldn't screen a clinic of 30, 40 people in a quick way. Each test takes about an hour to do. So I think we still have to find what the best way is to find a biomarker. I don't think we will ever find a single biomarker that will be giving us all the information. It will need to be a combination of biomarkers. And I think what the research is going towards is how to pull together as many simple biomarkers in a way that can be easily applied to low middle income areas, also particularly rural areas where access to facilities are not so easy for people to attend a clinic, and where the testing can be done in the community. So I think we're still away from that, Dr. Bajas, to find the best biomarker, and currently we rely on the ones which are more easily carried out and give us very good population level, but they don't give us that precision on an individual basis. So we hope over the next many years that the research will be refined as technology improves. I think as mobile devices like iWatches, portable devices are able to monitor and to be available in a cheaper way, these will, I think, help to give us more population-based biomarkers, which are relatively easy and which give it over a longer time.
Thank you, Professor Faisal, for the comments on question. So I think we don't are I will like to open again for if anyone in the participants faculties also, we have some faculty here attending this webinar. If you have any question, you can just raise your hand or just type on the chat room. Anyone? Yeah, so I guess we don't have the further discussion, but surely thank everyone for your active participation on today's webinar, Cardiovascular Disease and Tobacco Control, exploring current problems and future direction for public health. Also, a heartfelt thank you for our distinguished speakers, Professor Faisal Khan and also Professor Yai Suryo Prabandari, for their thought-provoking presentation. To all participants, your engagement during this discussion also underscore our collective commitment for this issue, cardiovascular disease, and also tobacco control. So together, we can explore and implement innovative solution for this. With many promising ideas to collaborate on, just like also what just Professor Faisal has just mentioned, that we also need to see the evidence on the collective simple measurement that will maybe also align with our national program, just like Postindu, we have national screening posts in have done in community with also involving the communities, Professor Faisal. So we also may have the idea for research collaboration, future collaboration with you from Dandi with Universitas Gadjah Mada for research, for teaching, and also for our community service. With this many promising idea to collaborate, now I would like to return the session to our MC. So thank you all, and I hope today's discussion inspires you, us, in having meaningful action for tomorrow. So have a wonderful day. I will just return to our MC, Mbak Zilvani. Thanks.
Mbak Silvani still mute. Thank you, Prof. Khan.
My pleasure. Lovely to see you all, and I hope to see you in person, inshallah.
Okay, inshallah. Yeah.
Thank you.
Thank you.
I think Mbak Zilvani has encountered some issue, so she used Mbak Nurul. Yes. So, yeah.
Yeah, bye-bye guys. Sorry because I can open my cameras, but Okay, thank you so much, Pak Bagas, then Professor Han and Prof. Yayi for the insightful presentation. But before we close the session, we can take a picture together. So Nurul will help us to take a picture. So to the all audience, you can open the camera, please.
Okay, thank you, Zilvani. We can start to the first slide. 1, 2, 3. Okay, next slide. 1, 2, 3. Okay, thank you.
Thank you for everybody. Thank you, Prof. Khan. Thank you, Dr. Bagas. Thank
Okay,
you, Pak
thank you.
Thank you,
Silva.
Prof.
So
Bye.
much.
Thank you.
Bisa nggak?
Bye.
Recording stopped.
Kenapa ya? Aku muncul nggak suaraku di situ? Enggak ya? Kenapa ya?